Good morning. I'm Lenny Bernstein. I'm a health and medicine reporter for the Washington Post. Today our second guest is Dr. Vivek Murthy, who was the 19th Surgeon General of the United States from 2014 to 2017. During his tenure, Dr. Murthy grappled with the Ebola epidemic. He put out in 2016 a comprehensive look at addiction in the United States, a document that was sort of a call to action, as previous Surgeon Generals have done with HIV and obesity. And most famously, Dr. Murthy spoke with Elmo from Sesame Street about vaccinations in probably his most widely seen moment. Today we're going to sort of take the temperature of the United States on public health, on some issues that you may have thought of and some others that you may not be thinking about. I'm told to ask you to please tweet us some questions on the hashtag #PostLive, and really please do, because it's a rare opportunity to ask questions to someone who really understands and gets it. There's lots of public health issues. We usually talk about opioids at these sessions, but I'd like to start with one that's really not gotten the same kind of attention. You have been speaking and writing about loneliness as a public health issue. And I'd like to understand how you came to that issue, and also why that is a public health issue.
Well, it's so nice to be here with you, Lenny, and Lenny's a reporter I have great respect for, and I believe the work that you do as a journalist is especially important now compared to any other time that we have lived in. Loneliness is an issue that I began thinking about actually quite some time ago, before I was even in office. When I was practicing medicine up in Boston, I was practicing as an internal medicine doctor, taking care of people with diabetes, high blood pressure, different types of cancer. But what I quickly came to see was that the most common illness that I was dealing with was in fact not heart disease or diabetes, it was loneliness. And loneliness that stemmed from a lack of meaning, a lack of self-worth, and a lack of social connection. And so I became intrigued by this and started to see more of this when I was Surgeon General, when I would visit communities around the country. Very few people would come out and just say, I'm lonely. That's not how people would talk about the issue. But when given the right opportunity, when asked the right questions, people would start opening up about the fact that they were in fact experiencing loneliness. Just a few months ago, for example, I was doing a radio interview, and there were several people who called in at the end. And one gentleman in his 40s called in and he said, my best friend died a few years ago, and I've been profoundly lonely ever since then. And I just don't know what to do about it. And as a guy, I feel like I can't really talk about that. It's not a very masculine thing to do, to say that you're alone. Another woman called in and she said, my daughter just came back from her first semester in college, and I sent her to college thinking she's going to be with a community of people that she's connected to, who she has fun with, who appreciate her for who she is. But instead she came back and she said, Mom, I'm connected to people all the time. We're texting each other, we're messaging all the time, but nobody ever asks me about me. No one understands who I am. I feel so alone. So I've realized that loneliness is far more prevalent than I thought. In fact, if you look at the data, the numbers are in the 20s to 30%, depending on the numbers you look at. AARP, for example, did a study looking at people over 45 and found that nearly a third of them are in fact experiencing loneliness. So this is a profound issue. It turns out it also has public health implications. Yeah,
you've written some pretty startling statistics about the impact of loneliness.
Yeah, so if you look at health, what you see is that people who are lonely live shorter lives. In fact, the reduction in lifespan associated with loneliness is similar to the reduction associated with smoking 15 cigarettes a day. It's also greater than the association with obesity. So just imagine for a moment how much attention we spend talking about, thinking about, and addressing obesity and smoking compared to how much we think about loneliness as a public health threat. But folks who are lonely also have an increased risk of heart disease, of dementia, of trouble with their fighting infections, so they have a weakened immune system. And they also have a greater risk of depression and anxiety. But the consequences of loneliness actually go far outside of health too. It impacts your productivity in the workplace, it impacts how our children do in schools. And what I've begun to see increasingly is that it also impacts our ability to dialogue as a community. And so if you imagine the times that we're in now, when we are struggling with major challenges, whether it's the opioid crisis or climate change or other chronic illnesses, these require us to be able to talk to each other, to dialogue as a community. But we can't do that if we are in the chronic stress state that is triggered by loneliness.
So why would loneliness have the same impact as 15 cigarettes a day, just physiologically?
So it turns out there are probably at least two explanations for this. One is that it looks like people who experience loneliness actually have a difference in the health-related behaviors that they engage in. So they may be less likely, for example, to make the right choices when it comes to nutrition and physical activity. But there's another explanation as well, which is rooted in evolution, which has to do with the fact that loneliness triggers a chronic stress state in our body. So if you imagine thousands of years ago when we were hunters and gatherers, being a part of a group was actually very beneficial because it ensured greater protection and a more stable food supply. In fact, when you were separated from the group is when you were more likely to get eaten by a predator or die from starvation. Now, you think about the fact that that has been baked into our nervous system over thousands of years, so that in the modern day and age, when you are lonely, which is equivalent of being separated from your group, having inadequate social connection, it triggers a similar stress response. And included in that stress response is hypervigilance, right? And so I mention this because in a situation where you are surrounded by predators, you want to be hypervigilant. You want to think that the rock that just moved over there might be an animal that's trying to jump out and come to get you, even if it's not. But in the modern day, if your hypervigilance leads you to suspect that people with good intentions have bad intentions, to suspect that people who perhaps aren't even interacting with you are trying to point at you or trying to threaten you in some way, you can imagine how this impairs our ability to actually dialogue and to interact with each other. But the chronic stress that stems from loneliness, we know that that stress is connected with inflammation, which in turn is connected with higher rates of heart disease and many other chronic illnesses. So there are biological mechanisms through which loneliness may have its effect. That said, there are probably mechanisms through which we don't understand. But the bottom line is when you look at all the data on loneliness, the statistics, the biology of it, what you're left with is the inescapable conclusion that we need each other. We are fundamentally social creatures. It doesn't mean we're all introverts or extroverts, but both introverts and extroverts need some degree of human connection, even if we differ in how much that is. We haven't prioritized that really as much as a society. In fact, it's not that we have said connection is not important. We've just allowed ourselves to think that many other things are far more important. We've taken our eye off the ball in investing in human relationships, and that has had its consequences in terms of our health.
Well, my kids tell me that they are connecting and hanging out with their friends. They're just doing it on phones and tablets and computers. Not the same?
Not the same. And the bottom line is not that technology is bad. In fact, I think, as somebody who spent years building a technology company and has used technology a lot, I believe in tech. I think it can be helpful to us. But technology ultimately is a tool, and how it's used is what makes a difference between whether it's helpful or harmful. And what you see with social media is that when you use social media as a way station, meaning if you use it as a tool for in-person interaction, as a bridge to in-person interaction, it can be quite helpful in helping build social connection, as it has been to me. So when I go, from one city to another, I might look up, friends on social media just to see, hey, which of my friends actually lives in Philadelphia now, or has somebody moved to Anchorage, or has somebody moved to Topeka? But if I'm primarily using social media as a substitute for in-person interaction, if I'm feeling lonely, for example, on a Friday or Saturday night, and I say, I don't have anyone to hang out with, but let me go on my social media feed and just scroll through people's posts, and then I'll feel connected to them, that actually tends not to work. In fact, in that case, you see that passive use of social media is associated with greater rates of anxiety and depression.
We can't just say, okay, I'm not going to be lonely any longer. What do we do?
So I think that there are a number of things that we have to do, like at an individual level and at a societal level. I think as a society, as organizations, whether you're workplaces or schools, we have to think about how we create environments that foster authentic human relationships. And I say authentic human relationships because this is about more than just hosting happy hours and throwing people together in a room. It's about very intentionally trying to create opportunities for people to get to know each other on a deeper level. People want to be understood for who they are. That doesn't mean that everyone wants to divulge their deepest and darkest secrets at work. But what it does mean is that they want to be appreciated for more than the person who knows how to do Excel spreadsheets and the person who's good at pricing strategy. People want to be known and appreciated as human beings, as moms and dads, as community members, as concerned citizens. But as an individual, and some of these actually exercises to enable that kind of interaction, we actually created and built when I was in office, when I was serving as Surgeon General, to help our own office foster stronger connections. But on an individual level, I think that there are also strategies that we can use. And I'll tell you this on a very personal note, because I myself am working on implementing these strategies in my own life, because I too have experienced loneliness in my life. That's part of what brought me to this issue. When I was a child, I was actually quite lonely in elementary school. I was very shy. It wasn't that I didn't want to interact with people, but I was lonely. And I had a wonderful family at home, but lonely at school. And I never felt comfortable telling my parents that I was in fact lonely, because saying I was lonely felt like saying I was not worthy of being loved. And that's what it feels like for many people to express their loneliness, which is why they don't. But this is why it was very personal to me. So coming out of office, I looked at my life and I realized that I had allowed work to edge out a lot of my close personal relationships, and that had led me to be lonelier than I thought I would be. And so the things that I'm doing now, which I think in general can be helpful, is one, is to draw boundaries around technology so that you don't bring technology into your in-person relationships with other people. So specifically, if I'm having dinner with my family, I try to leave my phone and my computer aside. If I'm catching up with a close friend, I try not to leave my phone open-faced so that I'm constantly looking at text messages or being distracted by alerts. But the other thing that I think it's important to do is to also ensure that each day we have at least some authentic interaction with someone that we love. It could be 1 minute. It could be 5 minutes. It could be a text message you send to a close friend. It could be a quick call you make to someone you love. It could be picking up a call when you get it. And I won't ask by show of hands, but I know that many of us, myself included, have been guilty of seeing a phone call come from a loved one and then just not picking it up because we're worried that it'll lead to a much longer conversation. And we don't want to take that risk, right? But what I have found is sometimes just picking up and saying, I can't talk to you right now, but it's so good just to hear your voice for 30 seconds. That makes a difference. So prioritizing relationships, protecting those relationships from the insidious invasion of technology, I think that these are both very important strategies to help us rebuild our connections in our life.
That's great. That's great advice. That's why the Surgeon General is America's doctor. A couple of quick questions about other public health issues that seem to have faded, possibly because we have made some progress, possibly because we're ignoring. Hypertension. Are we moving forward? Are we making progress on the amount of salt in our diet and the level of hypertension in the United States and all the problems it causes?
It's a great question. High blood pressure is certainly something everyone has heard about, but you're not reading about it in the headlines, every day. You're reading about the opioid epidemic, you're reading about violence from time to time. This is unfortunate because high blood pressure and cardiovascular disease more broadly is one of the leading causes of disease and death in the United States. And so one of the things that I think we have realized over time is that we have made advances in how to treat high blood pressure, in understanding what gives rise to high blood pressure. Where we have not made as much of an advance is actually reducing rates of hypertension, of high blood pressure in the United States. And I think that it's in part because I think we have not succeeded yet in taking a population-based approach to addressing high blood pressure. A population-based approach is not the same as an individual approach. An individual approach would say, okay, when patients come to clinic, then we'll talk to them about their diet and exercise and put them on the right medicines, and hopefully that will address hypertension. But a population-based approach says, can we do things like reducing the overall sodium content in the foods that we eat by working, for example, with packaged food manufacturers, by working with restaurants and others to reduce that sodium content, knowing that there's a connection between sodium content and high blood pressure. It also involves thinking about strategies for increasing physical activity. Can we create more green spaces, more walkable spaces that will allow people to be more physically active so that they can not only reduce rates of hypertension down the line, but also have other benefits. When I was in office, for example, I had released a call to action around walking in walkable communities. And the reason I had done that is because it turns out that if you walk on average 22 minutes a day and you do so at a brisk pace, you can reduce your risk of diabetes by 30%, your risk of heart disease by 20%. But we're not really seeing a big investment in creating walkable spaces. I guarantee you, though, if I told you that I had a pharma company that had a pill that if taken once a day could reduce the risk of diabetes by 30%, I think I would do quite well, right? Because people would say, hey, that's a solution that we should invest in. But we have solutions like that sitting right in front of us. They're called sidewalks, they're called parks, they're called walkable spaces. But we need more people to make the case to Congress and to other legislators that sidewalks are actually powerful public health interventions. They may not look like a medicine that fits in a bottle, but they can have quite an impact on our health.
If I'm manufacturer X, I'm not about to reduce the sodium in my product, risk the taste, the loss of the profits, the loss of sales, unless I know that all the rest of the manufacturers are going to do it. So how do we get that done?
This is where I think government has an important role that it can play. I'm not somebody who believes that everything has to be done by government or that the private sector necessarily has to be over-regulated, but I do think where the government can step in is to play a leadership role in bringing people together to make decisions that ultimately benefit all of us. And this is one example of that. Very few companies are willing to take a risk on changing the sodium content in their products on their own for the exactly reasons you mentioned. They're worried if their products don't taste as good or if they taste differently, that people will shift their consumption to other companies, to competitors. But the couple things that we know, one is that even if you were to reduce the sodium content in your food by, let's say, 10% or 20%, you might notice a difference, but over time, and over, in fact, the order of weeks or a few months, your palate will change, and it will acclimate to the new level of sodium content that you have. This is actually not just true with sodium, it's true with sugar as well. And we could do a similar thing with sugar as we need to do with sodium, which is to bring manufacturers together to reduce the sodium as well as the sugar content in their foods. Because right now, it turns out that close to 75% of packaged foods actually have sugar in them as well. Things that you may not think of, like pasta sauce and bread and crackers. But it is very powerful. And I know this in part from some, not just from the science, but from some practical experience. So when I was in office, a group of us on my team decided that we were going to do a quote unquote sugar detox. So we gave up sugar for a period of 30 days.
Just cold turkey.
Cold turkey. We just gave it up. And what giving it up meant that we didn't take added sugar in anything. We didn't buy or consume products that had sugar added to them that weren't natural. We could eat an orange, for example, but we wouldn't drink juices that had sugar added to them. What we found, which is really interesting, is our palate changed within the order of a couple weeks. In fact, one of the men who was in our group who was participating in this, he came back from lunch with half an orange. And I said, why didn't you eat your whole orange? He's like, I just couldn't eat it. It was too sweet. Everything suddenly tasted too sweet. So the bottom line is we are, as human beings, we don't have to be worried that if we change the sodium and sugar content in our food, that it's permanently going to change the quality of the food that we consume. Our palates will adapt, but the long-term benefits will remain. Government, though, I think can and needs to play an important role in bringing manufacturers to the table so that they can collectively make these decisions. And if they do reduce sodium and sugar content, even by an incremental amount, it can have a profound effect on the lives of millions of people.
And sort of convince them that everybody is going to go along if they'll acclimate to the same amounts of sugar across all these products.
That's right, yeah.
Quick question about smoking. It's down to about 15% of the population, yet it is still probably the single greatest risk factor, cause of death in the United States. What needs to be done? What's left to be done on smoking?
Well, we've made a lot of progress, but we do have a lot of work to do. In 1964, when my predecessor, Surgeon General Luther Terry, published the first Surgeon General's report on tobacco, smoking rates in the United States were around 42%. Dropping all the way down to 15% is a major, major public health victory. That didn't come easily. It came because of the hard work of people in communities across the country who built education campaigns, who came together to change policy, like increasing taxes on cigarettes and creating smoke and tobacco-free places. But it was an important victory. That said, we still lose about 500,000 people every year in the United States due to tobacco-related disease. And the more we learn about tobacco, the more we realize that there are more illnesses associated with it than we originally thought. So in 2014, in fact, when the 50th anniversary Surgeon General's report on tobacco was published, it was recognized that unlike 64, when there was one cancer that was seen to be associated with smoking, that was lung cancer, now there were over 13 cancers. There's also increased risk of diabetes seen with people who smoke. So like that, more and more we see added risks of smoking. What do we need to do? Well, I think for sure we have to double down on public health strategies that we have seen work when it comes to smoking. That means continuing to increase taxes on cigarettes. That has a profound effect on, particularly on youth utilization. So if we want to protect our kids, taxing cigarettes are actually a very important strategy. But the second thing that we have to do is we have to work on better cessation tools. We already have a number of FDA-approved cessation tools that are on the market. They work well for some patients. They don't work well for all patients. And so we need better cessation tools. Now, people have asked about e-cigarettes in this context. Are they the cessation tool that we've been waiting for? And I don't think we have enough science to say clearly that they are. But I do think that they're interesting enough that they merit strong scientific inquiry to see if they are, in fact, safe and effective tools for smoking cessation. What we don't want with e-cigarettes is for people to start using e-cigarettes and then to end up using both e-cigarettes and traditional cigarettes, a situation we call dual use. That has happened in some populations, but the only way to know if this works or not is to study it rigorously, and I think that's something that we should do.
I'm going to back you up back to nutrition because we have a Twitter question. Yeah. Why do doctors receive so little training in diet and nutrition when plant-based diets are scientifically shown to prevent and improve heart disease and diabetes?
So that's a great question. And in fact, I'll tell you what my nutrition education was in medical school. My nutrition education consisted of a 8-week class that was offered once a week in the evenings, and it was optional. So how many people do you think went to that class? There were about 6 of us, I think, in the class. One of them was the instructor. So not a whole lot of people. So traditionally, this has been a huge gap in medicine that we have. There are actually several gaps in traditional medical training. One is around nutrition. Another is actually around emotional health and well-being, which has a profound impact on our health, but which we don't really talk about very much in medical school. In fact, I'll say this parenthetically that the power and impact of emotional health and well-being is so profound on our health, and something I saw so clearly again and again when I was in office, that I decided coming out of office that what we needed to do was to really shift our culture and understanding around emotions so that we could understand the role it played in health, but also invest in cultivating positive emotions and teaching children how to regulate their emotions. And what we see when you do that is that not only can you actually reduce rates of addiction, major problem right now, but you can also reduce rates of violence. You can reduce incarceration rates. You can improve graduation rates and grades. You can reduce teen pregnancies. So the power of investing in emotional well-being is actually quite extraordinary, but has been barely tapped. And that's why coming out of office, I am working now with some colleagues to build an institute on emotional health and well-being that will help make that journey for us from a place where we largely ignore emotions to one where we harness them to improve our health. But part of what we need to change in medicine around nutrition is education. And that's slowly happening, but I don't think we can wait for medicine to get fully on board with training its clinicians to understand how best to deal with nutrition in the clinic. I do think what we need in addition to training doctors is we need public health strategies around nutrition. We talked about a couple of them, working, for example, with manufacturers to reduce sodium and sugar content. But we also need to do is thinking about the availability of healthy foods and beverages in our communities. We know, for example, that accessibility, whether in terms of both affordability but also in terms of location, is paramount to people's choices. If you work in an office building that doesn't have restaurants around it, but that has an office cafeteria, the food that's in that office cafeteria is going to have an impact on the choices that you make. And if there are healthy options, then you're more likely to make them. The Department of Defense, I had the chance to work with them when I was in office as part of the National Prevention Council, of which I chaired, which is a council set up by the Affordable Care Act, which brings together the secretaries of all the major federal agencies to think about how their policies impact prevention. And one of the things the Department of Defense was doing was actually experimenting with looking at their own cafeterias on bases. And what they found is when you did simple things like change the location of the grill and the salad bar to bring the salad bar closer to the front of the cafeteria, you could have a significant increase, in fact, on people's choice of healthier foods. So as these types of population-based strategies, I think are essential for us to take now if we want to affect as large a number of people as quickly as possible. Working with physicians and training nurses to have conversations with patients in clinics and hospitals is important, but I don't think it's going to happen quickly enough for us to ultimately get to where we need to be, which is a place where people can make healthy choices at affordable rates and ultimately live healthier lives.
Gotcha. I've left us about 5 minutes for the opioid epidemic. I see some glimmers of hope after covering this for 3 years. Prescriptions are down. Members of Congress are introducing dozens of bills to finally address the kinds of things that you have been speaking about and others have been speaking about. That has absolutely nothing to do with the upcoming midterm elections, of course. But overdoses will probably rise again in 2017 when we get the data. So particularly from fentanyl. So can you tell us where are we right now in the opioid epidemic, and what do you see going forward?
Well, you know, the opioid epidemic it's on so many levels, it's heartbreaking. I first started to see the impact of it when I was practicing medicine up in Boston and realizing that more and more patients were coming in struggling with addiction to opioids, and realizing that as doctors we had not been well trained in how to think about pain, how to address pain, and how to address addiction, save for addiction medicine specialists who are too few in number. So this is, but the tragedy of opioids also is that it's revealing something deeper that we are dealing with, which is not just a problem with prescribing, but as I came to see in communities all across the country, there's a deeper pain that people are experiencing, a deeper despair in their lives that is often being fed or temporarily assuaged by not just opioids, but by alcohol and by other substances that can easily be misused. And so if we ultimately want to address the opioid epidemic, we do need to change prescribing practices. We do need to expand access to treatment. We do need to get naloxone in the hands of not just first responders, but family members. But we also need to think more deeply about the root causes of addiction. You know, addiction in many ways is as much a social disease as it is a biological disease. And what I mean by that is that while addiction impacts us on a biological level, affecting our prefrontal cortex, affecting our extended amygdala, affecting our basal ganglia, all areas which are related to our ability to deal with stress and rewards and to control you know, decisions and such. While all of that is true, we also are increasingly realizing that the social context of our lives, whether we are fulfilled, whether we have meaning, whether we have social connection with others, also plays a role in our experience of and our likelihood of developing addiction. So I think that we have to really understand this in order to build a comprehensive strategy. I think where we are now is in a place where overdose deaths are still not decreasing. So we have a lot of reason to worry, but that does not mean that we are not making progress. So we are, for example, reducing prescriptions of opioids, which is important. We in fact have seen a near 25% reduction from the peak of opioid prescribing. It's still far above where it was in 1999, so we have a ways to go. Where we're also seeing progress is in extending medication-assisted treatment, which is evidence-based treatment with methadone, buprenorphine, naltrexone, extending that to people who actually need it. There's still far too many people who need treatment and can't get it, held back in part not just by funding, but also by a terrible stigma around medication-assisted treatment. But in places like Rhode Island, for example, we are seeing that the state has now moved to make medication-assisted treatment available in the prison system. And what that has allowed is for more people who need treatment to get it, and a reduction in overdose deaths by nearly 12% statewide in Rhode Island in just a year's time. We're also seeing in cities like Baltimore and others where naloxone is made readily available to first responders and to the public, that overdose deaths, in fact, or the people have been able to save a growing number of lives with the use of naloxone. And so I think there is reason to be hopeful. Some of these strategies are working, but here are a couple of things I think we have to do if we really want to accelerate this movement. Number one is we have to invest in these upstream prevention programs. By upstream prevention, what do I mean? I don't mean just changing prescribing. I don't mean just patient education about opioids. I mean investing in the many programs that we wrote about in Chapter 3 of the Surgeon General's report on alcohol, drugs, and health. Programs which are often school and community-based, which are relatively inexpensive to administer, but which can have a dramatic impact on drug use among children, adolescents, and among adults. Some of these programs, like the Good Behavior Games program, for example, for every $1 you invest in it, you see a $64 reduction in healthcare costs, criminal justice costs, and lost economic productivity. There are other programs like that too, the Life Skills Program, the Nurse-Family Partnership. But we have invested so little in those programs despite how much they can return. And I think part of the reason we've done that is partly not enough people know about them in terms of policymakers, but there's also a mentality that we want to invest in something today that's going to have a result tomorrow. But we need to play both the short and the long game when it comes to opioids, and that means investing up front. But the last thing I'll say on this in terms of what we have to do is that We also need to think about what's the appropriate role that each of us has to play here. This is not a problem, opioids, that the government is going to solve on its own. We need people in the private sector, individuals and communities to help step up and help us shift the culture around addiction, which still tells us that this is a disease entirely of choice, that this is evidence of a character flaw or a moral failing. And that is not the case. You know, addiction is a disease of the brain. It's a social disease as well that many of us could be a victim to and may already be victim to. And it's really often just dependent on the circumstances in which we live. So we have to remember that we each have the power to change culture when it comes to addiction. And if we can change culture, then we can change a lot of other things. We can make it easier for communities to accept medication-assisted treatment facilities. We can increase the pressure on elected leaders to invest in expanding treatment for the opioid epidemic. But this is what we have to do. And government, the role that the federal government, I think, can and needs to play now, is a role in setting a clear vision and benchmark of where we need to go on opioids. How much, for example, are we trying to reduce opioid overdose deaths in the next 1 year or 5 years? I don't think that has been stated clearly. How are we holding states and the federal government accountable also for doing the work that needs to be done on opioids, not just for passing bills, but responsible for changing outcomes. You know, I care less about a bill that's passed, I care more about an outcome that's achieved. And we might say that the bill is the method to achieving the outcome, but that's a possibility. It doesn't mean it's going to happen unless we hold our elected leaders accountable to those outcomes. So this is a place where I think government has a unique role to play. There's no private company that can set up and set a goal for the United States in terms of how much we should be reducing opioid overdose deaths in the next 5 years or 10 years. That is a place where I think the government has to step up. So yeah, so I was really privileged to work on this issue though when I was in office, because I do think that at the root of the opioid epidemic are deeper questions that we have to ask about society. What kind of society do we want to live in? Do we want to live in a society where we believe every life truly matters? Do we want to live in a society where we all chip in, recognizing that we are vulnerable in some way, whether it's to addiction or loneliness or other conditions, and that we are stronger when we come together, when we recognize our interdependence, and when we help each other? That's what, as tragic as the opioid epidemic is, if it can move us in a direction of shared understanding about our interdependence, if it can help us address these deeper social roots of disease, then I believe that we will have used it ultimately to improve ourselves, to become stronger as a country.
Thank you so much, Dr. Murthy. You gave us a lot to think about in just a half an hour. Thank you. Thank you. We're going to turn it over now to my colleague Paige Winfield Cunningham for the final discussion today with CMS Administrator Seema Verma. Thanks.